Yeah, good evening, everybody. Welcome to EEL edition 4 of Cases Under Discussion. Thank you for joining us tonight. This is 1 hour of case discussion. We are going to present 3 cases tonight, prepared by our young team from EEL member hospitals and clinics, and we have 3 experts tonight discussing with us, and we want to share opinions and options and possibilities on these cases. There's one case of deep endometriosis of the rectovaginal septum and the posterior vagina and the surgical procedure. There's one interesting case of bilateral deep endo of the ureter, and another case of adenomyosis. So I think it's a good mix. I would like to introduce briefly our experts that you might know already. I'm going to start with Horace Roman. I think everybody knows him. It's not easy to say in short words all your merits, Horace. I think it's difficult, but you are probably, or for sure, one of the best endosurgeons in the world, maybe the best one, and with very, very skilled, experienced team in your institute in Bordeaux in France. I think you are going new ways because you do exclusively deep endometriosis surgery with a very high volume of procedures per year. I just had a look at your webpage, instituteendometriosis.com, where you can see how many consultations you have per year, how many surgeries you do per year, and that there are more than 350 procedures in the digestive tract of female patients with endometriosis. You are one of our board members in the European Endometriosis League, and you have a professorship in Aarhus in Denmark. I think you did a lot of your education in Rouen in France before you changed to Bordeaux, and if I'm rightly informed, you are in Bordeaux now since 3 years. Yes. And we are very happy that we are going to be in Bordeaux all together in June next year. Maybe after my introduction, you can say some words to the postponement of the Congress. So thank you for joining us tonight, dear Horace. Then I would like to introduce Mohamed Mabrouk. He's another champion of endometriosis surgery, skilled and trained in Bologna in Italy, but also, as I found out, in Negra in Verona, con Marcello Ceccaroni. And Mohamed, you changed some years ago, it might be more or less 3 years too, from Bologna to Cambridge, and now you're a consultant gynecologist in Cambridge, and you are doing your endometriosis surgery, but not only endometriosis surgery, advanced laparoscopic and hysteroscopic surgery in Cambridge. And you got a PhD in the University of Amsterdam in the Netherlands. So thank you for joining us tonight. It's our pleasure and honor. And last but not least, I would like to introduce Joerg Keckstein. Joerg, you have been director of the Department of Gynecology and Obstetrics for many, many years in Villach in Austria. You have got a professorship in Ulm in Germany, and you have a long history of surgery, of development in endometriosis surgery, a long list of publications too, and you are the founder of the Weissensee meeting, which is a very, very important meeting in the German-speaking region, Austrian, Swiss, German region, in terms of development of new strategies in endometriosis diagnostics and treatments. And the latest result of this important meeting is the new hashtag ENCIAN classification, which has been published some months ago. Yes, thank you for joining us, and I'm happy that we can discuss some interesting cases tonight. I'm going to share my screen. And Horace, before we start with the cases, maybe you can say a few words to the new Congress date.
Yes, so after long discussions, we decided to postpone the EEL Congress in June, because the sanitary situation is not very clear in France and not in other countries, and it would have been a pity to lose participation of numerous colleagues coming from abroad because of this date, which was chosen before the COVID pandemic. But this date, the former date, was just 1 week before the Christmas, and I think that numerous colleagues coming from Asia, from foreign countries, could have canceled their participation because of this COVID situation, which is not very clear in France. That's why we prefer to move it in June, and all our industrial partners agreed and were comfortable and were even happy with this postponing. So I'm sure that we'll have a very successful meeting in June. Furthermore, in June, our town, our city is wonderful. So I hope you will be there, and we'll spend a very nice moment in this Congress, where we have very, very valuable speakers coming from worldwide.
Yeah, thank you, Horace. I add that I just got very good feedback too regarding the change of date. The people are happy with the new date, and I'm sure that we took the right decision, and we're going to have a very good time and much better time in June in Bordeaux. So we are really looking forward to be there. Okay, so let's start with the cases. The first case is from our department. In the last cases under discussion sessions, sometimes we just discussed one case, so I will speed up a bit today. This patient, when we saw her for the first time, was 34 years old. Chronic pelvic pain like dysmenorrhea, nulli gravida, no deliveries, not completed family planning. She had an abnormal uterine bleeding since a few months, maybe longer, and uterine growth in the last month regarding the outpatient consultant. She was seeking for a third opinion in our department, and she presented with an elevated CH12-5. In her medical history, as it was the third opinion, we found hysteroscopy and curettage in this patient for bleeding and the suspicion of endometrial hyperplasia. And the result of this first intervention was just hyperplasia without any atypias. And as I said before, no deliveries, no previous reproductive techniques, no relevant secondary diagnosis, no medication. In the examination, we found a normal gynecological examination without any findings, a small cervix, a globally enlarged uterus, which was mobile, but really larger than it should be, with normal adnexal areas and normal parametrian areas, and no palpable deep endo. So first question to our experts, what would be the imaging that you would go for in such a case in your usual daily routine? Would you do ultrasound, of course, but also MRI, or do you do MRIs in all cases?
May I say something?
Yes, of course.
Yes, of course. I think always ultrasound is always mandatory. So that's the first step. And if you have any doubt that there is some extragenital lesion, you can add the MRI. But first, I would like to see the ultrasound pictures.
Okay. This is the ultrasound. It's an abdominal ultrasound because in the transvaginal ultrasound, it was not possible to see the complete uterus. This is the uterus, and yeah, what would you say? How would you comment this finding? As you can see, it's about 18 centimeters in length. Yes.
Okay, and this is the anterior wall with hypervascularization.
Yes.
And in the middle you have because the diameter is about only 3.5 centimeters, as I see. The diameter anterior posterior is only 3 centimeters.
Where can you see that?
Because on the side. There is the schedule, you know, on the right side.
No. I mean, this is something like 13 centimeters.
But what are the measurements on the side? Yeah, what is this?
This is the positioning of the ultrasound probe.
Of the focus.
Yes.
But isn't this also the measurement? No, is
no.
It? Okay.
I think that's the velocity from the Doppler.
Yeah.
Because it's centimeter per second.
Okay. If Mohamed, what would you say?
This is 15 centimeters. 15
yes, 13,
in diameter.
14 centimeters.
14 centimeters. Okay, this is adenomyosis probably.
Yeah, looks like a focal adenomyoma. With yes, it looks like that.
No, I think
this is the only image that I've found, unfortunately. But this is the complete uterus.
Ah, okay. So it's diffuse adenomyoma.
This is the myometrium.
Endometrium.
It's very small, and this is the endometrium. The complete.
Oh.
This is the cavity of the patient. This is the uterine cavity.
Oh, okay.
So it's completely filled with that whatever material.
Mm-hmm. Very interesting. Yeah.
And she had a hysteroscopy before.
Yes. And there was hyperplasia without any atypia.
And with no masses inside the uterus at all.
Right. Yes.
So
this submucous adenomyosis.
Transmural, it can be transmural adenomyoma if that makes sense.
Diffuse adenomyosis.
Yeah.
So what?
But we should have a longitudinal.
The problem is that I did not have. I couldn't find it.
But then you make an MRI, I'm sure.
We make a tomography. But I do not have the pictures, unfortunately. But as I tell you, this is the wall, the myometrium, and the rest is endometrial-like tissue. So the complete uterus of extremely enlarged 34-year-old patient.
The problem is with this. Now to make a real good discussion.
Yeah.
We don't have a quiz here. we want to discuss.
Yeah.
And I think it's important, and this is the only picture we have.
Yes.
Then what does the CT, you make a CT, what does the CT say?
Yes, the radiologist said that the uterus is filled with endometrial-like tissue, and they couldn't distinguish between malignant or not malignant.
But the question that I have here is if you had a recent hysteroscopy and it was negative and there was nothing inside the cavity.
Yes.
So this seems to be something from the wall, but compressing the cavity. It could be something transmural, that is all the wall and just projecting in the cavity. That's what I can guess.
Yeah, in hysteroscopy, in hysteroscopy there was a hyperplasia. There was.
Yeah, I understand, but with the picture, the vision of the endometrial cavity, was there any mass, intracavitary mass, or it was a normal cavity?
So was there any sign? There was the cavity in the anatomical landmarks, ostia and so on. Was it explorable?
No.
Okay, so it wasn't normal.
No, it was abnormal.
Okay.
Yes.
So the hysteroscopy wasn't normal. There was something intracavitary, and you did a DNC or a curettage, and it was hyperplasia without a tipia.
Yes.
And
what we discussed with the patient, Joerg, you are right, and I take it as a I understand the critic here that we need more imaging. In the next case, we're going to have more images. The point here is that I want to go to the result of that case and discuss that with you. But what we did was we thought about, this could be adenomyosis, this could be some kind of fibroid, this could be sarcoma, this could be malignant. So that was the discussion that we made. And it was difficult to decide by ultrasound or by tomography what kind of tissue is inside of this uterus. And then we thought, okay, what are the options? And well, I wondered, would there be any chance to take out this lesion from this uterus? And I thought that it will not be possible. The other thought was, of course, about the family planning. And as there was a certain Doppler flow in that lesion, we decided to do a surgical treatment, and we did another diagnostic hysteroscopy, and we took another biopsy, and it was not a normal cavity. So the tubes were not visible. There was no normal cavity. It was filled by endometrial tissue with irregular vessels, and it started to bleed. Then we took a biopsy, and in frozen section there was the suspicion of some kind of intraepithelial neoplasia. We discussed that before with the patient and decided to do the laparotomy and hysterectomy in the same surgery. So that is what we did, and that was the finding. This is the normal myometrium that was visible in ultrasound, and the rest of this globally enlarged uterus was filled with this soft tissue, which was actually adenomyosis, and in the center of the uterus, intraepithelial neoplasia. And I found this case interesting because she was very young, and it was difficult to decide whether we opt for hysterectomy or not. And now I would like to have your opinions if there would have been any other treatment option, or what you do think about the relation between adenomyosis and possible malignant changes. This seems to be a very rare case because she's very young. But if we think about patients in perimenopausal age, it could be something of higher importance.
Parce que je suis dans son webinaire, d'accord?
So it is really interesting, and I completely agree with you that in my personal experience, I haven't seen a lot of these cases. This is the first case, I think. And here the situation is she had an ultrasound which was suspicious. She had, I don't know, I would have studied it with MRI as well, to be honest. The
Yes.
CT scan, yeah, MRI would have described also, I feel that it would have even given the suspicion of adenomyosis, because it looks like, yes, diffuse, but in being diffuse, it's focal. It's another big adenomyoma that's growing inside the whole wall, transmural, and arriving to the cavity. At that point, the hysteroscopic biopsy that we have taken is suspicious of malignancy, but intraepithelial neoplasia, I'm not sure that the best treatment is to excise her uterus, especially if she has not completed her family. And I don't know if at that point, if there wasn't intraepithelial neoplasia, it could have been also, I don't know, if you give her an analog for 3 months and then repeat the MRI again and to see, it's also only for the sake of preservation of her uterus and her fertility. But I understand that the plan was one surgery, do frozen section, and if there is any doubt, we will take the uterus out. If that was the plan, am I right?
My question is, Harald, this, you said the final histology. Can you explain how deep was the lesion, the malignant or the pre-malignant disease, and how was the remaining adenomyosis? Did it arise from the adenomyosis or not?
In this case, our pathologist said that it was arising from the adenomyosis.
And how many places? Was it all over the endometrial cavity? Because when I look here, the adenomyosis is, and on the ultrasound, the adenomyosis is very, very big and
yes,
surrounding the whole cavity. So how was the whole cavity? How was the histology? You made how many biopsies, or how many specimens they took out of this uterus, this big uterus?
For example, here in this area, you can see this tissue was macroscopically, and this tissue was with neoplasia.
Okay,
and
I see.
So it was a large neoplasia. It was not just a small area, but more or less the complete cavity filled with that material.
Yes.
Yes, Mohamed, it's an interesting point that you say that it could be treatment by GnRH analog. So, but what would be the, yeah, I don't know. I mean, I was scared that this could be already a cancer. I mean, we have an oncological unit too, and we see a lot of cancer in our department. So if you see something like that, of course, you might think in adenomyosis, but first of all, you think in some endometrial cancer or sarcoma or something like that. And it seems a bit risky to say, okay, let's try another treatment. Are there any other opinions? Horace, what would you say?
I agree with everything you said. So for me, it's a bit strange that you perform the tomography, because for me, the tomography of the pelvis is not the best exam. So I always use the MRI. Then the hysteroscopy is logical, and of course the diagnosis of intraepithelial neoplasia changes completely the strategy. And I think that even the patient, what was the opinion of the patient? I think that once she understood she has a big uterus with a tumor inside, I think she asked to remove it. What does the informed choice? What was the informed choice of the patient?
Yes, we discussed all the options with her, and I think it's a good point, because when she understood the problem, she opted for hysterectomy too. And the other thing is that this uterus would not have been a good uterus to have a baby. So
sure.
The only important factor would have been a pregnancy, and however, it would not be a good idea to have a pregnancy with that kind of uterus, and it might be impossible. So at the end, she was happy with the treatment and the result. So I think it was
just to make it I was just thinking inside my mind about another option. I completely agree that obviously it's the most important thing is to exclude sarcoma, and if there is an intraepithelial neoplasia, it's intraepithelial neoplasia of the endometrium, okay? And yes, if this is at the end what the patient wanted, I completely agree with you. I didn't mean to say, no, it's better. I was just thinking about other options. That's it.
Yeah, that's great, because that's the idea of our discussion.
Exactly.
That we try to find solutions. Yeah, the patient is fine, normal, regular follow-up, and she's okay with the treatment.
So did you find intraepithelial neoplasia also in adenomyotic lesions, meaning inside the myometrium?
Yes, the depth of the invasion of the neoplasia was different in different sides of the uterus, but it was like also invading the wall. Yeah,
because it was adenomyosis, and for that reason there was no chance to be sure that it's always interepithelial.
Yes,
that's absolutely correct treatment without any risk.
Yeah, I choose that case, and we have more of those cases because especially in peri or premenopausal women. And I think it's important to mention that in those patients with adenomyosis, we should be careful. We know that adenomyosis does not increase the risk of endometrial cancer, but there can be a coexistence, or neoplasia or cancer can arise from adenomyosis. So there might be a subgroup of patients with adenomyosis in that perimenopausal time, especially when they take hormone replacement therapy or tamoxifen for breast cancer treatment, where we should consider hysterectomy as a possible option. Because I think, and it would be nice to hear your opinion, it's difficult to check an adenomyotic uterus regarding endometrial changes in the perimenopausal time. Usually we very easily can check the endometrium in a peri or postmenopausal woman,
yes.
But in patients with adenomyosis, that's difficult.
It's very difficult, and in case the main problem is also, I had also some patients, the main problem if you have adenomyosis or in addition adenomyosis and fibroma, then it becomes very difficult to follow the patient with ultrasound because of the size and the localization of the pathologic findings to distinguish between a normal endometrium, normal anatomy. This makes it sometimes very difficult, and in that case I think MRI, as Horace already said, is very important to have a better imaging of the whole uterus, and and also you have to inform the patient that the diagnostic procedure has its limit.
Another question. What was the level of the CA 125 and why did you check it?
Good question. I tried to find out the level, but I couldn't. I have it in the hospital, but I didn't find it so fast. Yanis Vlachodimitris, do you remember the level? It was 300 something, or
I'm not sure, but I think it was about 200 or 300.
And
yeah.
why did you check it?
Yeah, just because I thought it might be adenomyosis, and I just wanted to see the level, if it's higher or not, to have another hint on the idea that I had in mind. So we know that adenomyosis can be linked to a higher level of CH12/5, and yeah, in this case it might be an option to just check it in one of the upcoming follow-ups in that patient to see if there's any elevation. But so far it's normal.
Do we have an explanation why the level of the CA 125 is increased in adenomyosis, which is an intrauterine disease?
Joerg, can you answer that question?
I have no pathophysiologic explanation, but it's endometriosis.
Endometriosis, anyway. Yes, but why adenomyosis?
This is
no peritoneal lesion.
This is a reaction. This is a reaction. I don't know the pathophysiologic pathway, why it's elevated, but I think that it doesn't make a difference if the endometriosis is interperitoneal or intra-ovarian or intrauterine, for my opinion. Do you have any data that there is a difference between these? It depends probably on the activity and the type of adenomyosis, probably, if it's more fibrotic or more epithelium and stroma. We have adenomyosis, which is most of it's fibrosis.
Yes.
As a reaction to the disease, but sometimes you have islands of mucosa within the myometrium, so it's more epithelial and stroma than fibrotic tissue. So
I think this could be a good study design to check levels and type of histopathology of the specimen. Yes. I don't know. I have no data in mind. Mohamed, do you have any clue?
Actually, I don't. I don't. I agree with George, because it depends on the type of adenomyosis and the percentage of glands and stroma compared to the fibrous tissue. I also understand that it's not peritoneal, but many times we see adenomyosis with very high levels of CA125. What I don't find an explanation for as well from your history is that this has changed. I mean, there is a rapid growth, and the clinical presentation is all in a very short time. Is that true?
Yes.
Yeah, it grew very fast.
Yeah, it's a strange case. Okay, I think we should go to the second case. Alin, would you like to present yours?
Sure, I'll do mine. So this is a 26-year-old patient, actually a medical student, who came with a diagnosis of endometriosis because her gynecologist saw a lesion in the posterior vaginal fornix, and they took a biopsy, and the biopsy confirmed the endometriosis. So she came to our endometriosis center. She was complaining of dysmenorrhea with a score of 5 out of 10, dysuria 5 out of 10, and also catamenial pain irradiating in labia major and the vagina. From the medical history, she had just a small surgery with a biopsy. She has prospective child wish. She had a couple of secondary diagnoses, Hashimoto, neurodermatitis, migraines, and depression, and she's taking an antidepressiva for the depression she had. The clinical gynecological examination showed 2 centimeters liquid bluish lesion at the level of the posterior vaginal fornix with a normal cervix. The rectovaginal examination and bimanual examination showed a 2 to 3 centimeter painful nodule at the level of the posterior vaginal fornix and the left and right uterosacral ligament. The uterus was mobile. So the first question would be, what imaging diagnostic would you propose in this situation?
MRI. MRI for me.
I always start with ultrasound. That's the first step for me, because I do ultrasound. I mean, I think, Horace, you do not ultrasound more?
I do not, yeah.
So that's of course, yes. I mean, this is something which is important. I think we have, when we discuss it now, this is very important. If you are used to have MRI, it's absolutely good MRI, no doubt. I mean, I think, but if you have the possibility and you are trained in ultrasound, I would start with ultrasound. That's my opinion. In fact, because the combination with the probe, you do a palpation, and you can, by palpating and imaging, you have 2 factors. You have the image and you have the reaction of the patient in addition. And this is a dynamic procedure in comparison to the MRI. With the MRI, you have a complete picture of the pelvis, which is sometimes not so easy with the ultrasound, of course.
Yeah. So you mean that the ultrasound is important when you perform it yourself? So it's a kind of a complement of your clinical examination. It's a much more advanced clinical examination.
Exactly.
Yeah. But when you do not do like me, you need also always you need an expert. You need to trust it, because in ultrasound you have no image. So you have one image, but you cannot read the exam of the ultrasound. It's a very dynamic. While the MRI,
I mean, this is the reason why I say we have to have the same language with the hashtag ENSIAN, that the sonographer has to make a correct diagnosis with naming exactly what you want to find. This is what is our problem with the radiologist as well. I mean, probably you are expert on MRI reading, but most of us, we are not so expert in MRI interpretation. I think, how is Mohamed, how is your approach?
I think it depends very much about where you work, the center where you work. So, for example, I used to work in Italy, where we used to have gynecology sonographers who were fantastic, very, very experienced. The school of Luca Savelli, Caterina Exacustus, and many others who were very good. And with time, we trusted them. So many of the cases we used to do ultrasound, and even we learned to do ultrasound as well. And I completely agree with you. It's a complementary to the clinical examination. Now, when I moved to the UK, this option does not exist anymore, because it's not part of the gynecological practice to have an ultrasound machine in your clinic, if that makes sense. So you have to send to the sonographer. And obviously, I'm not sure about the level of expertise of the sonographers, and to how extent you can trust this as a pre-operative tool for deciding and planning surgery. So we depend so much on the MRI now.
Yes,
and we are lucky that we have very good radiologists who are experienced in endometriosis, and that's why we go there.
But Mohamed, to be honest, I had diagnostic, I had reports of MRIs where I could see the nodule in the rectum, the adenomyosis, and it was not written in the report of the radiologist.
Completely agree.
We should mention also that making an MRI doesn't mean that the radiologist identify all lesions.
At all. And this is why even I take pictures of MRI when patients come to me with an MRI. I take the images and show them to my radiologist. And exactly, for a second opinion.
You have to read the advantage of the MRI, that you have the CD.
Yes, that's
You
right.
can read, you can see the same thing with the radiologist.
If they have, the slices are good and the quality is good, but in fact, if it's so that you have the advantage, you can go elsewhere. You can ask your special radiologist in your department. That's what I do as well. That's right. And what you can do, this is also good. You can copy this, and then you have it in the sheet. With the ultrasound, you have a few pictures, and so then, I mean, with the super sonographers, I think it's good. But in fact, Mohamed, now when you change, this is very interesting. You came from Italy, where the sonographers are very, very good. You go to England, where there are only a few, and why you didn't start it there?
Oh yes, that's what. Yes, actually, at the end, that's what we are doing. So it took me some time to make a business case and to explain that I would reduce the cost of the MRI. And I showed them that we can reduce the number of patients to do the MRI.
Okay.
And that's why at the end, they bought me an ultrasound machine in my clinic and myself to do the ultrasound. Yes.
I think you are all right. And for example, I also do my own ultrasound, and I'm very happy with that. And I think a lot of deep endo is visible by that transvaginal ultrasound. And in some additional cases, we also do MRI. And then I discuss the findings with the radiologist. And I think the most important point is that you have a good team building with your local team. And I think, Horace, that's what you did. You have an excellent team there with excellent radiologists, and you speak the same language, and you have your way to diagnose your patients. And Mohamed, you are doing the same, maybe in a different way, but at the end you have the same result. You have a pre-surgical idea of the extent of the disease. And Joerg, we also can do this by ultrasound, and I think there are many ways, but it is important to understand that that you need some kind of pre-surgical conference with yourself, or better with your team, in order to really have an idea about the case and the extent of the disease. Arlene, what did you do in this patient?
Well, I'm in that situation that I'm seeing with the ultrasound all my patients, and I'm referring them for MRI just in selected cases when I have the feeling that I need more info. Probably when the sacral roots might be infiltrated, or maybe whenever I have the feeling that the lesion is bigger going laterally to the parametrium. But in this case, I performed just the transvaginal ultrasound and the renal ultrasound. This is the bladder. This is the right ovary, which was looked adherent to the right pelvic sidewall, the left ovary with a small endometrioma, 2 centimeters, and also adherent to the uterosacral ligament and the left pelvic sidewall. Excuse me a bit. So this is the video showing the lesion infiltrating the posterior vaginal fornix, torus uterinum, and the left uterosacral ligament. And here you can see that the lesion doesn't infiltrate the rectum. Actually, the rectum is mobile. In the uterus, she also had an copper IUD. And here you can see the lesion infiltrating the posterior vaginal fornix and also the uterosacral ligament. So this is another capture showing the lesion over here, the lesion being mobile to the rectum. So it was a 3.5 per 2 centimeter lesion with another small lesion infiltrating the other uterosacral ligament. The renal ultrasound was normal. So the second question would be, would you ask for any additional diagnostic exams?
Yeah, I think we discussed that, yeah.
So the preoperative diagnosis, considering the hashtag NCIAN classification, would be O1T31, A3B02, sorry, B12. So the next question would be, which are the treatment options? What would you recommend to this patient in this case?
Mohamed, you're laughing. It's simple.
No, I'm not laughing. I think it's surgery.
Yes.
I'm a bit biased, but yes, I think it's surgery.
We all agree, right?
What was the main complaint?
Dysmenorrhea, dysuria, and also catamenial pain irradiating in the labia.
Aline,
Okay.
when you say dysuria, it means she has pain when she voids the bladder, or she needs to push to void
No,
the
she's
bladder?
pain. She doesn't have to contract twice or contract the abdomen. It was just
Even
pain.
within the periods, even during the periods.
No, just during the period. So 1-2 days before the period, but no pain outside the period when she has to urinate.
Mm.
So the pain she had was strictly related to her periods.
Okay, so she does not need to push with such a big lesion, bilateral infiltration. Okay,
No.
but I think I think we have to do the surgery prior. She needs to push because she's too young to imagine that during 25 years we can maintain this the size of the lesion without any evolution. What is her age?
She's
25.
26 and she's a medical student.
26, yeah. Mm. So she needed 13 years to develop such big lesion, and she has 26 years until the menopause, right?
Yes.
Okay. So I think surgery before infiltration of the rectum and before bladder dysfunction.
What is how about dyspareunia?
She didn't have any. She wasn't complaining about it.
How often did you see her?
I saw her once.
How long did she take the contraceptive pill?
She didn't take any contraceptive pills.
Does she want to become pregnant?
Yes, in the future, probably in the next 3 to 4 years.
Yes. So I personally would say I would start with a contraceptive pill in that case. And even if it's only for a short time, I think because you have both ligaments involved and the vagina is involved. Of course, you can do surgery. I think surgery is not so difficult in her case. But in fact, she's a medical student. I always want to tell the patient that there is another option because we cannot predict that this will be an infiltration of the rectum sometimes. We cannot say that. If we don't follow her, it may happen. But what you can do is you can see her after 6 months and so on, if you want, to see how is, because with the good ultrasound, you can follow these lesions very easily and you can measure it. If there is no change, then you have a very relaxed option to do the surgery when you want. This is something which I learned during my many cases I did, that I first tried to step back a little bit and to give her 2 options. And then you will see, because we have patients, and you know these patients, they have once there was a growing of the disease and it stops and it doesn't grow anymore. And this is something which you can only do if you control her by yourself and you let's say in a center situation. But I mean, surgery, of course, it's not so difficult, but if it's a big nodule, 3.5 centimeters, and in the vagina, it's not a small one. And you have both uterosacral involved. And it's not so seldom when you excise it entirely, so in total, that she may have some problems with voiding with the bladder. It may happen.
Sure, that's why
it's an interesting point.
Of course.
Horace, what is your opinion?
I think in her case, the major problem is the report with the splanchnic nurse. That's why I wonder she has no symptoms during periods, because usually this kind of patient,
and she can have
pain,
when you do surgery, she might get it.
Yeah, of course, and particularly during the first 3 or 4 weeks. But now we have to change. We have to choose either because you agree that this patient, when she wished to get pregnant, you have to do something with her. Of course, this kind of nodule, big nodule, or not so. The infertility is not mandatory, so she may be pregnant, but it's a kind of bet. So you bet that it does not not longer develop, and she's still
yes, but
fertile.
we have time. Endometriosis in this case, it looks the picture I had, and the endometrioma are small, but in fact I think you can do it. But you know, the deep lesion, which was obvious to see, is not so easy. I mean, for specialists, for you, Horace and Mohamed, but you also have these cases when they say now the bladder is lazy. The bladder is not normal anymore, which even when you dissect the splanchnic but if you go through and you cut it out, you may interfere the bladder function. I mean, it will not.
The bladder function might be much better after the surgery. That's also an option.
Why should it be better? Why?
I mean, we have cases with endometriosis and fibrosis in nerves, and when we do surgery, the function is better. Of course, it needs some time after the surgery, but there are cases that we do surgery for that reason.
What is your explanation for that? I mean, when you cut,
I mean, we do not do the resection of the nerves, but we do a liberation of the nerves and of the fibers.
You cannot liberate the nerves when they go through the nodule.
Yeah, Joerg, if the patient has a big nodule and the splanchnic nerves are not infiltrated, of course.
This is central.
The inflammation surrounding the nodule has an impact on the function. That's why the patient needs to push first during the periods.
That's right. That's the reason why I said I would have put her on the hormonal treatment and see what happens. Is this?
Yeah, of course, I don't. And then you have the proof. Surgery without hormonal treatment. So I give them a pill. So I don't want to say we perform the surgery right now, but I think that she needs a surgery before trying to get pregnant.
I think this is a good option, because when you give her the contraceptive pill, you can make the proof that if you reduce the activity of the nodule, then you can say it's the endometriosis which causes this problem. So then the indication for surgery is much easier.
I would like to ask another question. We are talking about maybe avoiding surgeries, which is a good idea. I completely agree. And we also discussed that, especially in even younger women. This woman has 26 years of age. And Joerg, I completely agree with you, especially when we talk about teenagers, about girls 19 years, 20 years old. Now she's 26. And I would like to ask you, what is the place of diagnostic laparoscopy in that cases? Or are we so good in diagnostics now that we do not need the laparoscopic view? Do we trust in our MRI so much and in our ultrasound that we say, okay, we do not need any laparoscopy? And I just would like to mention those cases taking pills from 20 to 35 without having any complaints, then stopping the pill because they want to become pregnant, and then they notice that they have a severe endometriosis with adhesions and peritoneal and deep endo disease, and it's difficult for them to become pregnant because they just have their surgery very, very late and their treatment very, very late. So what is first your opinion on diagnostic laparoscopy, and second on the time delay that might happen when you do the treatment with the pills?
Yeah, what I can say is a diagnostic laparoscopy at the moment when you have good sonographers, or you do the sonography or the MRI, it will not give you much more important about deep endometriosis. It gives you more information about superficial endometriosis and adhesions probably. And what you said, that after 10 years, suddenly she has got a deep lesion. This is not, I think it's only rare cases, because if you have seen this patient 5 years before, you personally, you would have identified the lesion already. These are these patients being in outpatient control, in not specialists. They give the pill and then they stop and they become symptomatic, but they had the deep lesions since many years. This is what you are absolutely right. But I think in hands of you or Alin, who does the good ultrasound, I think it's not dangerous to wait for half a year, 1 year, only in cases when they get lost.
Yeah. Mohamed, what would you say?
I personally believe that, for example, this patient had also some neuropathic pain in the vagina and the vulva, and I would suspect that she has some nerve compression somewhere, or some nerve affection somewhere. And obviously, it goes without doubt that you have to offer all the options to the patient: medical treatment and surgical treatment. And the ultimate choices for the patient, and as Horace published in 2010, is the informed choice. So it is, we are moving around this. We have definitely to offer everything, unless there is organ damage or there is impairment of function, or we offer this. And in my personal opinion, diagnostic laparoscopy in the context of deep endometriosis doesn't have any rules. Doesn't have any rule at all. We do diagnostic laparoscopy, but the disease, when we do diagnostic laparoscopy, we study the intraperitoneal cavity, and the disease is retroperitoneal.
Yes, exactly.
So it doesn't have any, in my personal opinion. And many times it also, on the contrary, it makes more harm than benefit, because she has the diagnostic laparoscopy, sometimes done by a colleague who is fantastic, but he's not experienced in endometriosis, and he puts the stamp, "Madam, you don't have endometriosis at all." And this is where she continues to have problems, and she doesn't seek medical advice, because we all know that she doesn't have endometriosis.
Horace, what would you say? Oh, sorry, Mohamed.
Yeah, no, that's fine. That's fine. Please, Horace.
Okay.
Yeah, I agree with what he said. Completely agree.
Okay, perfect. Alin, would you like to show the surgery?
Yes. Actually, I offered the patient the possibility to take some hormonal treatment for 6 months and see how she would feel. Probably because of the medical background, being a medical student, she came with a fixed mindset and she said, "No, please take it out. I want the excision." So the hormonal treatment wasn't an option for her, and she wanted the surgery. She came with this mindset already. So what I proposed and what we performed was the removal of the copper IUD, then the endometriosis excision, first starting transvaginally, and then placing a Mangeshikar manipulator, and then laparoscopy. So this is the surgery. The left ovary was attached to the left pelvic sidewall and to the uterosacral ligament. And there in the Douglas is the big lesion, 3.5 centimeters. Then on the diaphragm, she also had 2 small lesions, which look superficial. So I started the surgery in a standard manner with a adhesiolysis of the sigmoid colon and identifying the left urethra. Then the ovarialysis, and that's the the small endometriosis cyst that was opened during the dissection. So I just performed an incision and then did a lavage. Then I suspended the ovaries on the left side, on the right side. And then I started the dissection on the left side by mobilizing the left ovary more. Then I try to stay as superficial as possible, removing the disease.
Yeah, as we can see, it's already complex surgery. And Joerg, that's what you meant, right?
Of course, I mean, that's not so, it's not a simple surgery. But your diagnosis was absolutely correct. Perfect. Congratulations.
Thank you. So first I tried to circumcise the lesion and try to remove everything in one specimen. So what I always do, I place a gauze on a forceps and I place it in the posterior vaginal fornix to understand better the anatomy. I know that Horace prefers to put his finger and feel the lesion. And I try to go as superficial as possible and try to open the vagina as late as possible.
Do you think that when you have a scar at the end of the vagina, this could be a problem in the future in some patients, like causing dyspareunia, or I mean, I don't have that feeling. I think it's a safe and feasible procedure.
Not actually, because it is hidden behind the cervix. So in my experience, the dyspareunia due to the scar is so rare.
So we already have 8:05, and I just want to mention that we are going to finish this case and skip the next one for the next discussion round.
I think 3 cases, if we thoroughly discuss each one, I think the 3 cases is too much for a webinar.
Yes, that's
because we exchange a lot about our which is a very, very good point. I think it's much more even very interesting.
Yeah, we always prepare 3 cases, but we never did 3 so far.
So this is the lesion which was first dissected transvaginally. And I prefer this approach because this way I'm sure that I'm removing the whole lesion that's infiltrating the vagina.
The whole lesion and not too much vagina, so maybe you're more more conservative on the nerves.
Yes, and the vagina was closed in a double layer running suture with a PDS thread. And then there was another superficial lesion in the right ovarian fossa. And the whole surgery was performed with just 3 trocheries, 1 for the camera and 2 5mm for the instruments. And the lesions on the diaphragm, they were superficial, and I managed to remove them without opening the diaphragm.
The problem with the lesion of the diaphragm is that most of them are behind the liver. So in this case, usually I do not treat them. I ask to the because in 75% of cases they are not symptomatic. In my Syrian, I saw that Marcello Ceccaroni has the same data, and when they are symptomatic, I perform an MRI of the diaphragm, and usually I perform the surgery on the lateral decubitus to have the whole diaphragm exposed. So I do not longer treat them during the same time with the pelvic lesions.
Yeah, it seems to be better to have a different assess if you want to reach the diaphragm, because usually you have the trocar of the optic in the umbilicus, and you need to do more trocars in the upper abdomen, and yeah, sometimes that's difficult for the patients too when they have 2 or 3 more incisions. So I completely agree.
And also, I have to add that for diaphragmatic endometriosis, sometimes you remove asymptomatic lesions. And I personally have seen a patient that had this lesion removed, and she had the phrenic nerve irritation and the significant shoulder pain that she didn't have before surgery. So if it's not symptomatic and it is there, sometimes we used in Negra, we used to argon laser with argon laser beam to coagulate it, or with plasma jet. But I mean, if it is asymptomatic, sometimes I really just document it, and it is there, and then explain to the patient that in the future, if you develop symptoms, there was some superficial endometriosis in the diaphragm.
That's what you're doing.
Okay, great. Aline, maybe you can tell us the final classification and the post-surgical treatment that you recommended to the patient.
Yeah, so the surgical diagnosis was a P2O1, T3, A3, B1/2, and F diaphragm. Yeah, so the next question would be, how do you comment the perform treatment? That was discussed already. And what's your proposal for the post-surgical treatment? And what I recommended in this case was a hormonal treatment with combined oral contraceptive in a long cycle, rehabilitation in an endometriosis center, given the fact that she had a deep endo, and also a regular transvaginal ultrasound once per year.
Does she void the bladder correctly without significant post-voiding residue bladder volume?
Actually, she was planned to come now in October to do the ultrasound and see how she's feeling. After she went home after the surgery, I agreed with her that she would let me know if she had any symptoms, but she didn't give any signs. So I assume that she's doing well. So I'm supposed to see her again now in October.
Aline, I want to ask you to give us an update on this patient in our next discussion round, which will be probably in December. And I would like to end this case now, because we already have lost a lot of time now. Maybe Engin Oral, you are there, and you can maybe you can say some words about the upcoming webinar, which will be on the 19th of October. Okay, so the next activity will be the webinar series with Luke Rombots from Australia, and he's going to talk about surgery or IVF for endometriosis-related infertility, which is a very interesting topic, I think. And we invite you to join us 19th of October, 7 p.m. Same link for registration. And we are going to continue with the 5th edition of the Cases Under Discussion series, probably in December, and we will have another nice cases there and another team of experts. And I would like to say thank you to our experts tonight, Horace, Mohamed, Joerg. It was great to discuss with you. It's always interesting because some cases seem to be so clear, and then we have a lot of opinions, and it's more difficult than one might think. So it's great to see that there are different ways, and at the end, yeah, we still can all learn a lot, and that's why I think 1 hour of discussion it's always worth it. Thank you for joining us tonight, and I really hope, and I'm sure that we're going to see each other in June next year in Bordeaux. So good night to everybody, and many thanks to our experts and everybody. Thanks to our young team. Okay.
Good night. Bye bye.
Thank you
Bye.
very much, Harald.
Thank you.
Bye-bye.
Bye.